Welcome, everyone. We are here with Leslie Shover, Dr. Leslie Shover, who has over 30 years experience in working with sexuality and fertility, especially in the cancer arena. She's worked both at MD Anderson and at the Cleveland Clinic. She's seen patients, done research. Leslie is now founder of a new service. It's called Will to Live, WILL, the number two, live, which will to love.
It's
Uh,
actually built to love.
Live and love, isn't that kind of
That's
synonymous in a way?
right.
Yes. Thank you. So thanks for correcting me. That's right. It's Will to Love, which is an online service offering support related to sexuality and fertility, including telemedical services. So welcome, Dr. Shover. Thank you for being here.
Well, thanks for inviting me.
Um, Help us get just a broad overview of the issues that men face when they are struggling with, specifically with erectile dysfunction. Where do they go? Who do they talk to? Are there doctors a place that they should be going, and are doctors open to these conversations?
Well, I think it's very common for men to talk to their primary care physician. Sometimes it's like on their way out the door, oh, by the way, doc, I have this problem, because it isn't easy to bring up. And unfortunately, physicians are so busy that they often do not routinely bring up sexuality, which they ideally should every time you have a checkup. One problem is that primary care physicians vary tremendously in how open they are and how knowledgeable they are to talking about sex. So sometimes men can kind of get a brush off. Certainly, primary care physicians should be very aware that ED is often a precursor of heart disease and other diabetes and other health conditions. So, if for no other reason, it's important. But I think men often get a better response when they do see a urologist, especially, one who specializes in the different ED treatments and can discuss the whole range of possibilities.
Right. The issue, of course, is that most men see primary physicians far more frequently than they see urologists, who may be more open to these discussions. You touched, I think, on a really important point. You linked erectile dysfunction with other systemic illness, diabetes, hypertension, heart disease, and so on. And what strikes me about it all the more is the way you described the interaction. You said kind of on their way out the door. If in fact erectile dysfunction is a sentinel of other very important diseases like diabetes, it seems to me that it ought to be the first thing you ought to be asking about, not the last thing you ought to be asking about, because decline in erectile function may in fact be the first sign you get. Uh, let's move on here. You also, as long as we're talking about the primaries and the potential treatments, let's say the conversation is happening. I know that in our current environment, where the pharmaceutical companies are so dominant on the airwaves, the discussions in the primary care's office is often around medication. And in fact, if you're a busy primary care guy and you don't really want to talk about erectile dysfunction, the easy solution for you is to write a prescription and say, see you next time. Let's talk about the different treatments for erectile dysfunction. How good are the oral medications in the context of things? How good are they relative to the other options, like the inflatable penile prosthesis on the other end? Are they as satisfying? Do you have any thoughts on comparing the different approaches to managing erectile dysfunction?
I have a lot of thoughts about it. Well, for one thing, for a man who doesn't have any, major identified health problems, it may make a lot of sense to start with oral medication. I think what the pharmaceutical companies are not very honest about is that those medications work really well for men who can get almost a firm erection and just need a little bit of extra help. But the men who really have severe erection problems often don't benefit very much. And certainly the men that I've seen over the years who've had pelvic cancer surgery for, prostate or bladder or colorectal cancer very rarely get a really good erection with those medications unless they were 42 years old and had super erections before their surgery.
Right. But of the men who try these different things, I mean, you've been at this a while and you've seen them try all the different approaches as they come and go. Do you have any sense about which of them may be the most embraced by them, or which of them are they most likely to continue to use after experimenting? Because, look, in my urology practice, I've seen men try all of them, injections and vacuums. But the issue is they often don't stay with them because for one reason or another, they're not satisfied. I want your perspective.
No, I think that's very true. And I think I could cite you several research studies, one of them my own, with big groups of prostate cancer survivors that show that the great majority of men, within maybe 3 or 4 months or 6 months, drop out of all those treatments. They stop using the pills because they don't work. They stop using injections because they're painful or a hassle, and often the same issue with vacuum devices. The suppositories tend not to work very well for the great majority of men. So the one treatment that really stands out as having much better satisfaction and much better adherence over time is the inflatable penile prosthesis. And I will say that when I was young and I was there at the start at Baylor when Brantley Scott and his colleagues were first doing those surgeries, and I was kind of appalled at the whole idea. But as I've over the years, I've come to see that I think it's really one of the best treatments we have in terms of, really helping men and couples. And I can't, tell you how many men have said to me, "Oh, I really wonder why I waited all those years to try it."
So you brought up another really important dimension, right? So in this case, the patient is really the couple in a way, if you want to, if you'll allow me some poetic license with that.
Sure.
And what you're saying is that you're seeing satisfaction not only for the man but also his partner, another for the patient but also his partner, both.
Yeah, I think that when a man finds a treatment for AD that's satisfying to him, that if the partner has a wish also to have a happy sex life, that the partner's satisfaction tends to go right along with the man. I mean, one problem in older couples is often they may have gone through years of not having satisfying sex. The woman might have pain because of menopausal symptoms that haven't been addressed, and not all the women are enthused and happy about the idea of having a more frequent sex life. And that's where often some couple counseling and a consult with the woman's gynecologist and things like that can come in to try to get both partners on board.
So what you're saying is that sexual satisfaction is about numerous events coinciding. A physical erection can't, doesn't have to be, but certainly can be part of the experience. But there's more to satisfaction than just having an erect penis. In other words, there's a whole emotional and interpersonal duality that has to be taken into account. I mean, that I think in and of itself is the subject of a complete other discussion, obviously.
Right.
If we can just complete, I have one more question in regards to the inflatable penile implant. Um, are you seeing patients ask for it? Are you seeing them having any any problems in getting it, either because their doctors don't understand what they're talking about, or because insurance isn't paying for it, or for any reason, really, administrative reason?
Well, for me, because the last 10 or 15 years of my career, I've had a research appointment and I haven't been out there as much on the front lines. I may not have the best answer for that. My impression is that a lot of men's insurance doesn't cover it. And then that can be a huge barrier because it's expensive. And that's one thing that I think that Sergio, can do a great service for men in helping them to make it somewhat more affordable, at least for middle class patients who may have to pay some or all the costs out of their pocket. Also, John Mulhall, who's at Memorial Sloan Kettering and has done a lot of really great research, did a study and found that minority men, African American and Hispanic men, were more likely to request or go all the way to having a penile prosthesis. And I think some of that may be because of cultural factors where masculinity and self-esteem are so linked to erections. I think they are for all men, but I think especially in minority groups sometimes.
Well, yet another nuance to bring into the story. So, uh, with your permission, let me see if I can just rearticulate and summarize what I think you're telling our audience. The conversation about sexuality isn't a simple one, certainly not with the doctor. Many doctors are either too busy or too unaware of the broad clinical implication of erectile dysfunction and so don't necessarily attend to it sufficiently, certainly not from the perspective of the patient. Secondly, while there have been many, many treatments developed over the years for erectile dysfunction, having the treatment available and being aware of the treatment is not the same as trying it and staying with it, because not all treatments that exist are actually effective and embraced by the patients. When it comes to penile implant, you've been around its evolution for 30 years. You saw it as something that was used, I think you used the word appalling initially, when it was first invented, but in fact you've seen it in its evolution. You've seen how it actually fills an important role for both partners in the sexual duo, and it is your impression, actually I think you cited some research studies, that it is probably the most satisfying of all the different treatments that exist for erectile dysfunction. And then finally, of course, we have to leave ourselves open for the sequel, which is to say that is not the end of the discussion. There's an awful lot more that needs to be said if you're to have a satisfying sex life, and that you're off to a new chapter with your startup, Will to Love, WILL, the number 2, love.com, where you're going to be offering the benefits of your 30 years of gained wisdom through online and perhaps other services. Did I get it? Was that right?
You got it, absolutely.
All right. Well, thank you, Leslie, and we'll talk again.
Thank you.
Okay.